Is it possible to end AIDS as a public health threat by 2030? The United Nations thinks so, and the guests on this podcast series certainly hope so. But it's going to take effort, innovation, connections between people and within communities, and funding. Welcome to Can We End Epidemics, a podcast series by the global biopharmaceutical company ViiV Healthcare, in association with its biopharma majority shareholder GSK, and developed by FP Studios. I'm Henry Bonsu. In this episode, we ask what it takes to deliver health impact at scale. This is something that our guests today are busy trying to address through their work with Amref and GSK. How can we build resilient systems to improve public health and eliminate infectious disease by 2030 and beyond? Let's see what they have to say. Dr. Mercy Mwangangi is Director of Health Systems Strengthening at Amref Health Africa and the former Chief Administrative Secretary for Kenya's Ministry of Health. And Fiona Smith-Laittan is Vice President and Head of GSK's Global Health Strategy and Impact. Welcome to both of you.
Thank you.
Thank you.
So Dr. Mercy, let's start off with the partnership Amref Health Africa and GSK launched to improve treatment and diagnosis rates in Ethiopia and Kenya vis-a-vis malaria and TB over a 2-year program. How's that been going?
Thanks, Henry. So our partnership with GSK includes improving access to treatment. So we, in both countries, currently stand at around 40%, and we've been aiming to double this to 80%, ensuring that communities have access to diagnostic services and also to medication and commodities. I think it's important to understand that this partnership is centered on strengthening systems. And it's very easy, particularly when you're not in the health sector on a day-to-day, to anticipate that the interaction with the health sector ends at the hospital. But for us, public health practitioners, we feel strongly that systems are the key to unlocking impact when it comes to health systems and health outcomes. And so our partnership is leveraging on communities, centering our efforts and our interventions on communities, and ensuring that communities are able to get access to the medicines that they need, access to the health interventions that they need.
So how have you done?
I would say we've done fairly well, particularly looking at the crisis that we were facing. So remember, this partnership begins, and then here comes COVID-19, which caused, a displacement in essential health services. I think what was useful for me, and particularly being in the front lines of the COVID-19 pandemic in Kenya then, is that this partnership allowed for us to ensure that there was continuity of essential health services. And just to paint a picture for you, most governments, when the COVID-19 pandemic hit, all their efforts and attention and resources were geared and targeted towards COVID-19. And so, as expected, there was, lesser focus on core essential elements, such as malaria and TB control and management. And so in being able to have this partnership and have that work and this investment continue on was really pivotal. I think also we need to appreciate, so the world focused on this pandemic and we lost lives. But if we compare, and you could never compare diseases, right? A life lost is a life lost, whether by malaria or COVID. But the impact of malaria and tuberculosis is much higher than the COVID-19 pandemic impact, particularly at country level. And so, again, this partnership allowed us to be able to ensure that we are meeting our essential strategic program needs while still dealing with the pandemic.
I was just going to say, malaria is almost particularly at risk for continued funding, isn't it? Because some of the focus came off that we're not going to meet the elimination of malaria by 2030. It is very climate sensitive, and there's been some backtracking over the last few years. So actually keeping the focus on malaria and keeping it embedded in healthcare systems was really important to both of us.
And Dr. Mercy, I've done a fair amount of work with WHO Africa region myself, and there are lots of things that make Kenyans and Ethiopians ill, and other Africans too. We could talk about non-communicable diseases too, cardiovascular diseases, cancer, and then diarrheal diseases. So why the focus on malaria and tuberculosis vis-a-vis health systems?
Good question, Henry. And you're right. Africa is dealing with what they call the triple burden of disease. We've always had infectious diseases. We're still fighting to control infectious diseases, and we're seeing an upsurge of non-communicable diseases. I think what's important, Henry, there is you can't choose a disease because success in health outcomes is actually dependent on systems. So think of systems as the vehicles that assist any interventions that you put into the system. GSK works in doing R&D and providing these innovations and technologies. But then you need a partner who understands local systems, who understands national plans, who's able to understand the weeds of delivering and getting these innovations to the people. I would want us to use that framing every time we're looking at a health system and, is it malaria, is it TB, is it cancer? At the end of the day, the system needs to be strong enough and robust to be able to actually deliver good health outcomes.
Right. And Fiona, when it comes to GSK's partnership with a particular country, I want to know in a bit more detail how that works. Let's say a country like Ghana is very concerned about maternal mortality or concerned about yellow fever, but you might think, hey, we've got innovation and we can do something to help you with HIV, AIDS, or tuberculosis. How do you align to strengthen both the individual fight against a particular disease and the broader health system?
Absolutely. The needs of the country has to come first. And I think that's probably, you'll know more than me, Mercy, been a shift over the last 10, 15 years where actually there were lots of vertical programs going in that were actually just what the donors or the implementers wanted to do. So absolutely it needs to be led by the government and it has to be integrated in healthcare systems in the country as opposed to something separate. For us at GSK, we are focused on infectious diseases for global health, and we are primarily focused on TB, malaria, HIV through ViiV, and also antimicrobial resistance. So we know that's where we have expertise and current partners. So for us, we would work in those areas and choose to work with partners in those areas, but with interventions that go beyond just those diseases. So we would not do just a standalone yellow fever program, even though that might be a government priority, because we don't feel that we could bring anything in addition to that, and it's not linked to where we're doing our innovation. So short answer, all programs need to be led by the governments, and we would want to row in behind that to guide which programs in which countries to work with.
All right. Dr. Mercy, you've been working with 9 key countries across Africa, apart from Ethiopia, Zambia, Malawi, Senegal, Burkina Faso, South Sudan, Uganda, Tanzania, and my beloved Ghana. Now, looking at their health systems, reform and priorities, what are the challenges that they face in achieving successful health systems? Because I suspect some of the challenges are common across those countries and some might be particular.
Yeah, I just want to sort of center this around Fiona's last point that TB, malaria, and HIV do account for the highest burden of disease in all those countries that you've mentioned. When you look at their mortality studies, when you look at their morbidity studies, you're not going to miss TB, malaria, and HIV. And so that's getting into your question as well with the 8 and 9 countries that you've mentioned. When we look at the health system, what are countries struggling with? It's always good to start from the positive end. Most countries, and particularly since the MDG era, the 2000s .com eras, have been able to look at the health systems and define what priorities are. And that's really crucial because they know where the challenges are and they know what they need to do. And this is really enshrined in different policy frameworks, in different guidelines, in different program action plans. So most countries more or less know where the pain points are, and they know and they can actually quantify how much investments are required. But with that knowledge then comes in the challenges. And the biggest challenge I would say right now, particularly in Africa, is the fiscal space challenge. Funding, yeah. So countries are struggling with debt crises or near debt crises. We have, of course, the geopolitics that's going on around the world, the economic disruptions, the potential conflicts, the pandemic, which we are still dealing with in some shape, way, and form. And so the biggest constraint is how do I make this dollar, shilling, kwacha spread a little bit further to meet the needs that I've already defined and prioritized? And do I put some money into TB, malaria, or should I also be able to recruit new healthcare workers? As we speak right now, Kenya is undergoing strike industrial action. Doctors have downed their tools. In the same country, of course, we still have priorities when it comes to malaria, TB, etc. And so the government is always, at any one point being faced with an opportunity cost. Where do I put my dollar or my shilling to be able to get the health outcomes that I'm pursuing? And particularly with the private sector, is in view of this debt crisis, in view of this tightening fiscal space, government needs to crowd in partnerships, and you can no longer ignore the private sector. The private sector is agile. The private sector is able to bring innovation to the forefront. And so it's become almost, if not necessary, required to get closer to the health outcomes that we're seeking. In tandem with that, of course, is investments in R&D. If I can remember when I was sitting back in Kenya, I think it was probably about 2% of our health budget was allocated to R&D. And so you can imagine what can 2% do for you. And this is magnified if you go across the 9 countries that you've just mentioned. And so then again, you need a private player, a partner who's able to make this seed investment, get the R&D going, get the innovations and technologies that we need to be able to combat disease and move towards UHC. And then, of course, I wouldn't finish this without mentioning the role of the healthcare worker. People and policies. I've heard you say that before. I've had various people in the global health space talk about people and policies. We need to invest in our healthcare workers. We need to invest in our community healthcare workers. We need to invest in our tertiary healthcare workers. And that is a challenge in Africa.
Fiona, I'm wondering how true that is in your experience, especially when you contrast what's happening in the global south, particularly in Africa, with what's happening in the global north, in European countries, in the USA, where there's also massive pressure on health budgets and a global war for talented health workers. And many of them are being tempted to come from Africa to Europe.
I know, it's terrible. The brain drain of talented, trained doctors from Africa, even to Europe and the UK, is huge. And that is actually an area that we have identified, probably discussions with Amref in the past as well, as an area that we might have a role to play. So we have this programme in GSK called Africa Open Lab, where we give grants to young up-and-coming African researchers and medics who might be tempted to leave and come and do research in well-funded institutions in Europe or the US, but to actually do the research which is needed by them in their country, build up the capabilities, build up their labs, with some support and some financial support from GSK in order to keep the thriving community of researchers and clinicians where they're most needed. One of the reasons we did this is because there's an amazing woman in my team, Juliet, who is a Ghanaian infectious disease doctor who came over to the UK to work at the London School of Tropical Medicine, who had a great career and has not gone back because the opportunity to do the work that she ended up focusing on just was not there in Ghana at the time. So how can we break that cycle and actually build the capability with money and funding and exciting projects where it's needed?
Right. And Fiona, can you give us an example of a project that GSK has funded and then scaled up to improve an aspect of healthcare in a particular country? I say this because your goals might be slightly different from the broader strategic objectives of a particular country. And it's important to try and distill the two.
Yes, and I think it's interesting as well how, given the amount of money from the private sector is not enough to fix it, plus funding has to essentially be domestic. We've asked ourselves some interesting questions, challenging questions about what our role is. And I think we believe that it is to work with partners to do catalytic projects which can then be scaled. So as part of that, it's perhaps doing riskier things that the government might invest in upfront. The one I think I'll talk about was a program that we started, I think almost 10 years ago with Save the Children in Kenya. And it was around kangaroo mother care. So better care of premature babies with skin-to-skin content. And we started that in Bungoma County in a couple of healthcare centres. GSK provided funding. The rest of it was integrated. And the outcomes were so great, and they were published and shared, that I think is now being rolled out more broadly. I visited a centre actually where it is now being completely integrated. And the WHO has also used this as an example to roll out more broadly. So I think there are great examples of doing things, trying things that are maybe a bit risky, measuring them, publishing them, and then with that, hoping to make them sustainable with domestic long-term financing.
I was actually deputy minister at the time. And so I do remember receiving the Bugomba report. And I do remember also working with different partners, WHO, UNICEF, to actually scale up kangaroo mother care. But what's interesting, and I'll give you a little example of what I mean. When the project was being scaled up to different hospitals, we actually involved the healthcare workers, right? And we asked them, hey, we have this technology, and this is really a service delivery innovation. We have this service delivery innovation where if you provide skin-to-skin contact with a mother, particularly for preterm babies, you would be able to ensure that the babies gain weight, et cetera, et cetera. And I do remember some nurses saying, this is fantastic, but then perhaps we need to relook at our ward We need to ensure that our infrastructure is actually able to meet the merits of this new service. And then we had some nurses say, and how about the men? How about male partners? How do we involve them in this innovation? How do we create spaces and rooms and waiting bays where male partners can come in and sit with the babies and hold them chest to chest and help them in gaining their weight? So there is sort of these subtle elements that are almost implicit that in any partnership between the public and private sector, between the NGO, private, public sector, you do need to co-create, you do need to have local partners, you do need to understand local needs. And, that really does also enshrine Amref's modalities of work. There's no one project out of our 293 projects that is done without co-creation with government partners.
Mercy, that's amazing to hear that you were there at the time and you were there and part of the scaling up and seeing it from the other side.
Great. Okay. Well, let's talk also about the country-led approach. I think we need to delve into it in a bit more detail. What are the priorities for governments who are being told at a multilateral level and beyond that you need to invest more in domestic resources, you need to devote more of your national budgets toward healthcare? And sometimes you find that healthcare becomes a Cinderella compared to other departments. How do you work with a government that says we simply haven't got enough money, Fiona?
Well, I suspect Mercy is much better positioned to answer this question. But what I will answer from our interaction is we would never start a programme on any project that wasn't a government priority and didn't have government support, because there have been enough cases over the last 30 years of great initiatives that come, and as long as they're funded, they have an impact, and then the second the funding stops, they stop. So that can never happen again. So we would only even start if there was a route to sustainability, and our partners on the ground would tell us that.
Mm-hmm. And Mercy, please, I've been to so many events, so many conferences where government ministers, health ministers are being told, you need to stand up, you need to fight your corner, you need to be banging on the door of the Treasury and saying, we need more funding. Otherwise, we cannot deliver the healthcare outcomes we want. And that feeds into the whole of the rest of the economy. If people are sick, they can't work, children cannot study at school. And as a result, we have worse growth and we are more dependent on the outside world.
Henry, I'm right there with all those people that you meet in those conferences, and I'm joining that choir, I'm joining that church. We do need to continue advocating for more resources in health. It's easy to sort of sit back and wonder, oh my gosh, health is getting all the attention, but we do need to look at the data. If you look at total health expenditure of all the countries that you mentioned, the 9 countries that you mentioned, none of those countries is at the limit of $80 per capita spend for health. And the $80 mark, why I bring it in, while there's a lot of controversy that surrounds it, has been a peg mark for WHO in terms of, if a country can invest $80 per person, then at least we're seeing progress towards better health outcomes. And like I put there an asterisk, that is controversial, but if you look at most countries in Africa, few of them have been able to meet that target. If we compare this with countries in Europe or the Americas, Canada, I think, is at $4,000. So for one country in Africa spending, let's say half of that, $40, there's another country doing it 100 times more. So at the end of the day, we do need more money for healthcare. And at the same time, the few dollars that we have, we do need to ensure that we are more efficient in their utilization.
And Mercy, I've been talking about Africa as though it's a monolith. Of course, there's great variation between the countries, even the 9 countries we mentioned earlier. And I'm wondering, from your experience and your visits, which countries are getting closer to that goal of providing universal basic healthcare and a resilient health system? Can you give us an example, a positive one hopefully, and explain why that particular system is now becoming more resilient?
Yeah, off the top of my mind, definitely I would mention Kenya, and that's not because I'm from Kenya. But right now, Kenya has put in place legislative frameworks that will ensure all citizens are able to access care through a social health insurance fund.
But Mercy, if I may, there are lots of countries, including my own country, Ghana. Ghana also has put in some wonderful legislation and great policies. And when I go and visit my relatives, can they get basic health care? Many of them cannot. And so they say, Henry, please send me funds. Henry, please send me funds. So
That's
much as I
true.
respect the presidency
That's
and everything
true.
they're trying to do.
So, and I have to say this, we need to understand progression. As countries move towards UHC, No one country, even in Europe, has been able to get it all right. Ghana has been a fan favorite, actually, for a while in the global spaces. Lots of tours have been done to see what Ghana have been doing. But remember, we discussed this earlier, debt crisis and challenges in fiscal space have come in to hamper the great work that the Ghanaian Ministry of Health and the NHS have been doing. Progress does happen. It just won't be a big pendulum swing. And particularly in Africa. And so we do need to appreciate the little catalytic changes that take place. I'm going to mention
let me
Mali.
interrupt you again.
Mali.
Sorry. No, wait a minute. Okay, it won't happen immediately, but what are the signs that we should be looking for? Because this is going to be really helpful for our listeners, okay? What are the signs we should be looking for to demonstrate that progress is being made?
Perfect. I would say, Henry, having sat at the helm of leadership, if the political class and the technocratic leaders are paying attention to our health system, and that this then extends outside of the Ministry of Health, that you hear the Minister of Finance talking about the health system, that you hear the Minister of Water and Agriculture talking about the health system, then something is happening. It won't be this cosmic shift that will happen there and then, but something good is happening. Number two, the voice of the citizens. When you hear the people continuously agitate for better healthcare services. When you look at a paper from Ghana or the Nairobi Star from Kenya, and health is on the front page, then it means something is changing. And so I really do believe highly in the political voice, but also primarily the community voice. I think at the end of the day, data. You could have all the best intentions, but if we're able to look at your budgets, if we're able to look at your allocations and appropriations for health and compare them, 2 years ago, 10 years ago, where were you? And we see a positive, steady increase, then something is going to improve. I think also private sector participation is a good signal. When you see partners such as GSK, Fiona here, and other members paying attention to a country, then it means the ecosystem is ripe for partnership. It means that people are actually dedicating efforts to the health system, and that's a positive indicator.
And Fiona, let me ask you this. People have talked a lot about leapfrogging, not just in the global south, but elsewhere too, not least because of the COVID-19 pandemic and how quickly a vaccine was developed and mobilized around the world. It shows what can be done when everybody is aligned. And I'm wondering, what can we learn from this in order to make better progress in the fight against AIDS, TB, malaria, and other epidemics?
COVID really did focus the world on the value of science, the value of healthcare workers, and the value of bringing everything together in a system that works. And I think that was unique and has changed the world forever. What can we learn from that now? I think it is partnerships. I think COVID worked because of broad partnerships. They worked with partnerships in the research and development side, but partnerships with the rolling out. There were some things which didn't work around the allocation necessarily in the vaccine and the fairness. And I think that has also changed the narrative for good on that. And there's certainly much more voices of African countries demanding things that they need themselves than there was before COVID. There has been a lot of technology that was used around the rollout of COVID and records and vaccination records, which I think have also changed things for good. And actually, that's one of the areas as well that I think we're working with you on in Amref is better handheld technology for patient records. So an app with a small device that healthcare workers can take with them, capture information about what they see in front of them, vaccination status of people, of malaria in the region, etc. So I think there is definitely something around tech tools that have been used more and more recently that really could be the way of lower income countries leapfrogging all of the big, sometimes quite unwieldy sort of mainframe computer systems where everything is stored into having a much more agile way of collecting and distributing data.
Mercy, how would you respond to that from your vantage point?
Oh, yeah. A very, very, very needed innovation. I do remember, and it's a situation that's similar in Kenya, Ghana, South Sudan, that you'll find a health center manned by one nurse and perhaps one administrator. And this one nurse has to fill in probably 5-6 volumes of registers, as well as attending to the patients. So imagine having this tool that's able to translate and make her work easier. It would be monumental, even in freeing some workload hours for her to be able to attend to patients. I think in this new day and age, you use the word leapfrogging. I don't think we would be forgiven 100 years from now if we don't take advantage of the technologies that exist. Increasingly every day, if you look at simple things like forecasting drug consumption, right? And GSK would be familiar with this. How can a government actually estimate the true need of malaria medication? And now we have tools and technologies that are able to do a lot of supply chain quantification and forecasting. And so really, we would not be forgiven if we don't leverage on these technologies years from now.
And data and surveillance are increasingly critical, aren't they? And there's gaps in data everywhere around the world. But for infectious diseases, and what we learned from COVID is that very fast turnaround from data to understanding sequencing, looking at optimizing treatment, where are the gaps, was critical. So I think that's going to be another enduring.
For sure. And you mentioned antimicrobial resistance. Henry, I'm sure you've had this more and more. We're getting closer to a time where we may go back to World War I, II eras where some basic antibiotics like penicillins don't work anymore. And that would set us back eons of years and would be probably detrimental just as much as COVID-19 was, if not more. How do we support governments to ensure that they're keeping their eye on that? And, if I could share a personal story, I do have a friend recently who was scampering around trying to find his mother antibiotics from India, just because the first line, second line, third line, and fourth line treatments were no longer working in Kenya, in one of the biggest private hospitals in Kenya that has everything that you would need. And we essentially had to use our networks to bring in antibiotics from India. So you can imagine at large scale the effects of this. So definitely data, surveillance is very key.
So, Dr. Mercy, okay, let me ask you this. How far away do you think we are before we can say that a significant number of African countries have a realistic chance of getting to universal basic health coverage? This is the holy grail. Everybody wants it. A system where it is either low cost or free at the point of need for most people in that country.
This answer won't make you happy. I think we do have a long while to go, but I do think we are making progress. We are moving in the right direction. There is a big report that's about to come down, the countdown to 2030. As you're aware, we have the Sustainable Development Goals that would be coming up the year 2030. And so Amref and WHO and UNICEF and the World Bank and Gavi and Global Fund, a whole number of ecosystem players are counting down, and they're working on a big statistical report that will share where the world is. And I could steal a few pointers for you. It's not looking good. We're not getting there. We won't get there by 2030. However, it still does show that there is some positive direction of travel in most indices.
Thank you, Mercy. And Fiona, I suppose I would ask you why GSK does this. You're a very successful global pharma. You're not a charity in the generic sense. So why does this make good business sense for you to partner with all these organizations and all these countries in this way?
We are an innovation-based company, and innovation without people and access to people and the systems around it is not worthwhile innovation. So that is the first. It's absolutely a key part. The second is it's good for the world. And as a healthcare company, I don't think we can ignore the fact that there are some big health inequities around the world. And to address those, it's going to take more than just provision of medicines and vaccines. It actually needs some systematic changes, and that's why we have partnerships. And the last reason, which I haven't mentioned up to now, is our employees really, really care about it. Whenever there's anything in the news, there's a lot of questions about what GSK is doing. Our employees care about it and expect us as a company to represent them and all the time that they give the company and to do the things that they would want to do. And I think we've noticed that it's good for retention, it's good for attracting people. So yes, it's the right thing for our innovation, but also our employees care an awful lot.
Thank you very much indeed to Fiona Smith-Laittan and Dr. Mercy Mwangangi.
Thank you, Henry. Thank you, Fiona.
You've been listening to Can We End Epidemics, a series of 6 episodes where we discuss disease prevention, health inequalities, the future of medicines, and health funding, among other issues. Do check out the glossary in our show notes for any terminology you might have missed. I'm Henry Bonsu, and until next time, thanks very much for listening.